Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. I've been a cardiologist in Houston for more than 40 years. The focus of this presentation is on antiplatelet agents, anticoagulants, in the presence of atrial fibrillation, acute coronary interventions, and beyond. So let us begin with the feature presentation. The feature presentation is ACC AHA 2020 Guidelines for Anticoagulants and Antiplatelets in patients who are undergoing coronary interventions in the presence of atrial fibrillation or thromboembolic events. Some basic data before we get started with the presentation. Approximately 2 million stents are placed in the United States in year 2021. And most of these patients require antiplatelet agents such as aspirin along with clopidogrel or ticagrelor. 10% of the patients with the PCI have atrial, you can follow my green arrow here, have atrial fibrillation needing an additional antithrombin drug such as warfarin or any other newer antithrombin drugs. 25% of the general population develop atrial fibrillation sometime during their lifetime. We are talking about 1 out of 4 adult person who can develop atrial fibrillation during their lifetime. So atrial fibrillation is one of the most common arrhythmias, but it's also one of the most significant causes of embolic strokes. As is said here, the next line, atrial fibrillation accounts for 15 to 20% of ischemic strokes. And there's a strong recommendation for oral anticoagulant therapy in patients with atrial fibrillation based on their CHAD-2 VASc score to minimize the risk of stroke. In fact, anticoagulants have been shown to reduce the incidence of ischemic stroke in patients with atrial fibrillation by almost 50%. So that's a significant benefit. The challenge that we face when we are talking about antiplatelet agents, anticoagulants in patients who are going for coronary interventions who may or may not have atrial fibrillation or history of deep venous thrombosis leads to either stent thrombosis, embolic events from the blood clotting in the left atrium, or if the blood thinning is too much, it can result in excess bleeding. And it has been shown that in certain conditions, the excess bleeding with the triple antiplatelet anticoagulant combination could be 2 to 3 folds that of if that person was only on either antiplatelet agents or anticoagulants or antithrombin. Anytime somebody has excess bleeding, the risk of death by stroke goes up by almost 5-fold. So this is a pretty strong and important point for us to understand so that we walk the delicate balance between keeping these patients from clotting while at the same time minimizing any bleeding risks. So let us begin with some basic concepts. Aspirin, P2Y2 inhibitors, namely clopidogrel or ticagrelor. Then we have direct oral anticoagulants. Then we have low molecular weight heparin. Then we have vitamin K antagonists. When we are using multiple blood thinners, we need to have these patients on histamine 2 receptor antagonists and proton pump inhibitors. And when there is no longer a need for triple antiplatelet or anticoagulant, we need to make sure we taper these medicines appropriately. And here are some of the abbreviations. AC stands for anticoagulants, antiplatelet therapy, dual antiplatelet therapy, doacs or direct oral anticoagulant, oral anticoagulant agents. The doacs could be vitamin K antagonists. And when we use doacs in the presence of other medications, we need to keep their INR between 2.0 and 2.5. These are some of important points. Then we have single antiplatelet therapy. Let's begin with a clinical scenario. Here we may have a patient who has history of atrial fibrillation, who is on anticoagulants. now has a PCI. What do we do? Because for PCI, we generally put them on aspirin and one antiplatelet agent, P2Y12 inhibitor. But how many drugs do we keep them on? How long do we keep them on? And which one do we taper or take off? The second scenario could be someone who is on antiplatelet agents because the person has a stent. Now this patient develops a new onset atrial fibrillation. How do we switch over to an appropriate combination? As the antiplatelet agents work on the platelets, whereas the anticoagulants prevent clot formation. What about a person with a previous history of venothromboembolic event like deep venous thrombosis, who is on anticoagulants with either vitamin K antagonists or antithrombins, and now has a PCI? What do we do? We're going to find out. Now we have new or recurrent VTI in a patient who is already on dual antiplatelet agents for a coronary stent. So there are various scenarios which we need to take into consideration. This is just 4 broad groups. There could be other situations where we have patients with reduced left ventricular ejection fraction and other bleeding problems, all of which have to be taken into consideration when we make a decision. Let's say we are talking about an elective or an urgent PCI in a patient who is on vitamin K antagonist. That means this person has history of atrial fibrillation. This person is receiving an anticoagulant, or this patient could be on a newer antithrombin drug. So how do we handle that? Basically, we need to bring the INR to less than 2.0, and before the procedure, they need to be switched over to IV unfractionated heparin if needed, and administer aspirin according to ACC AHA guidelines for PCI. Whereas if these patients were on doacs, hold the doacs for a certain number of days, which we will show in table number 5. Similarly, this is an emergency procedure. You don't wait, you just go ahead and do the procedure and deal with the correction of coagulation status later on. Same thing, you just stop the medication, but you proceed with the procedure. Once the procedure is done, the patient receives a P2Y12 inhibitor with a loading dose like clopidogrel 600 milligrams once. Then we can initiate IV unfractionated heparin or low molecular weight heparin or bivaleuridine, but as you know, bivaleuridine just lasts for several hours. So if you need a longer term anticoagulation, the best option would be to use low molecular weight heparin until such time we can resume the oral vitamin K antagonists or doacs. When patients go through PCI, it is preferable to use doacs versus vitamin K antagonists such as warfarin. They can also be maintained on aspirin less than 100 milligrams per day along with the P2Y12 inhibitor. And when they're on these medications, at least for 1 month, and then aspirin can be taken off, but they need to be treated with proton pump inhibitors and H2 blockers. If they are on vitamin K, consider vitamin K plus bridging with low molecular weight heparin. If not bridging, administer aspirin 81 milligrams. And as I said, the triple anticoagulant regimen can be continued for 1 month, but at the end of 1 month, we have to stop the aspirin to minimize the risk of bleeding. This is just sort of an expanded version explaining the same thing which I just did in the previous slide. So let us move on to the next one. Now we have a patient with atrial fibrillation, indefinite atrial fibrillation, and long-term oral anticoagulants who needs PCI. So what do we do? This patient is on vitamin K antagonists, or this patient could be on doacs. In those cases, we follow the PCI peri-procedural management as explained in figure 3, which we will get to. Anyway, so post-procedure, we prefer DOACs over vitamin K antagonists. They can be started on oral anticoagulants, and they can be continued on oral anticoagulants, continue on P2Y12 inhibitors, and we start these aspirin for a period of 1 month, triple therapy. Along with that, we continue with PPI and H2 blockers. And now, what do we do in the post follow-up period? In the post follow-up period, the first month we continue with the P2Y2 and the anticoagulant. Over 0 to 6 months, we continue the clopidogrel, and after 6 months, continue P2Y2 or switch to aspirin. But most people would drop the aspirin and continue with the P2Y12 inhibitor, and at the end of 12 months, all of these agents can be stopped if we can reasonably do so, or we can just continue on low dose aspirin, less than 100 milligrams. Preferably we have 81 milligram aspirin. So those are the things, and in the meantime we continue with oral anticoagulants, because atrial fibrillation is a chronic condition. It's a lifelong issue. They need to be on long-term anticoagulations. So that is a kind of a foundation, and on that we determine as which drugs we kind of juggle around here on the antiplatelet side. Same thing for PCI with a bare metal stent. This is for drug-eluting stent. For a bare metal stent, for the first month, we keep them on P2Y12 inhibitors along with oral anticoagulant agents. And between 0 to 12 months, they stay on Plavix preferably. But if it is necessary, we can stop that after 1 month in patients with the bare metal stent. Now, here is a complex chart which is looking at the patients has a stent and now has a new onset atrial fibrillation. What are we going to do? It looks very complex, but the main thing is we need to know where to find the resource when we need it. We don't need to memorize everything. We need to understand the concepts of antiplatelet agents for stent, anticoagulants for atrial fibrillation. Atrial fibrillation is a long-term management. Stent treatment can be stopped after like 3 months, 6 months, or 1 year interval. Based on that, here we have a stable ischemic heart disease with no acute coronary syndrome. If that is the case, if the drug-eluting stent is less than 6 months or a bare metal stent less than 2 months, we can start them on oral anticoagulant and stop the antiplatelet agent. Similarly, if we have an option of either starting these patients on DOACs and stopping the aspirin and continuing the clopidogrel, which is the preferred method of treatment, which I told you in the previous slide. If the drug-eluting stent is between 6 to 12 months, then we continue with the oral anticoagulants, and either we can continue with aspirin or clopidogrel. The preferred choice would be to continue clopidogrel. Similarly, you can go down this line depending upon the condition of the patient and the history and see what is the best option for these patients. As I said, the oral anticoagulants are the foundation. Because of chronic atrial fibrillation, they need to be on it to reduce the incidence of stroke. Basically, we have an option of continuing the aspirin and Plavix, or just continuing with Plavix for extended period of time, namely 6 months or a year, during which time aspirin could be dropped to minimize bleeding. So that's the main essence of this. We need to learn concepts, and if you want to refer this back to based upon a particular history of a patient, like here we started off with the stable ischemic heart disease. Here we have a history of a patient with this cerebrovascular accident, CVA, or a peripheral arterial disease. So you can just come back to this chart or make a copy of this chart and put it on your bulletin board. Then you have a practice guidelines directed treatment option that are readily available. Now let's talk about a patient who is on antiplatelet agents, that is, who is on antiplatelet agents for a stent. Now he has new atrial fibrillation. Now we are talking about a new atrial fibrillation. First, we had to determine, is this a candidate for an oral anticoagulation therapy? If the patient has a significant history of bleeding, no, then we had to find an alternative method. If the patient is able to tolerate oral anticoagulant agents, then again we need to go back to what is the underlying problem besides the fact that this patient has a stent. Is this for primary prevention of arteriosclerotic vascular disease, atherosclerotic vascular disease, stable ischemic heart disease, history of an acute coronary syndrome, history of cerebrovascular disease, or history of PAD? And when we are dealing with, again, we're going through this less than 6 months, 6 to 12 months, and 12 months, and we come down here, we have the same sort of guidelines. So you get the concept. I mean, that is the main thing. I don't think we should really memorize the whole chart here because there's no way we can memorize, but we know. So the thing is, if you are dealing with a patient who is on antiplatelet agents for a stent placement in the past, now develops atrial fibrillation, and what do? If the patient had a stent, say, from 6 to 12 months, we have an option to continue or start oral anticoagulant agents. In all these cases, you're going to start the oral anticoagulant agents, which could be long-term. Then you decide about either to continue with aspirin or clopidogrel. Again, the preferred method is to stop the aspirin and continue with clopidogrel for the duration of the clopidogrel requirement, which is usually 6 months minimum or 12 months for drug-eluting stent and 30 days for bare metal stent. After that, we can resume aspirin if we feel that is necessary, but the oral anticoagulants will continue onward. Now let's look at a patient with a venous thromboembolic disease who is going for coronary intervention. Obviously, this patient is already on oral anticoagulant agent. Now we have to decide, are we going to add aspirin and Plavix? Again, we go back to the same situation. It doesn't matter which one comes first. It's a question of which agent do we use to minimize bleeding and maximize prevention of embolic events. PCI, unable to be deferred until anticoagulant treatment is complete. If it's an urgent PCI, then we follow this pathway. If it's an elective PCI, then we follow a different pathway. Here, we're going to look at what the pathway is here because it's on the next slide. So if this is an elective PCI, let's go back here. This is an urgent PCI. We follow this pathway. We have like different pathways based upon what the patient is getting for atrial fibrillation. And here is the chart coming down here. If the patient is on vitamin K antagonist, we can switch them over to low molecular weight heparin. If this person is on still initiation dose, this is the pathway we follow. If the patient is already on treatment, then these are the pathways we need to follow. So we have an option to use doac along with P2Y12 inhibitors in these patients. And when we use these agents, as I said, you need to continue them for 12 months, the P2Y12 inhibitors, and after that we can just continue with oral anticoagulation as it is indicated for either deep venous thrombosis or for atrial fibrillation. And when these patients are on P2Y12 inhibitors along with doacs or vitamin K inhibitors, they need to be on proton pump inhibitors and H2 blockers. Aspirin should be limited to no more than 30 days in the initial stages following stent placement. If the person is on like a short-term anticoagulation for a deep venous thrombosis in the leg, maybe the doctor recommends for them 3 months or 6 months, what do we do? Again, we need to go back to what is the condition that we are dealing with. Is this a stable ischemic heart disease which needs a drug-eluting stent? Can this wait for 3 months or 4 months? If it is, then we can stop the anticoagulation and just treat the stent management as we normally do. But if you have to intervene, then obviously we need to look at 2 agents with perhaps maybe time-limited aspirin. Same thing with PCI, with acute coronary syndrome. Here we don't have a time frame to play around. So basically we're going to be on anticoagulants, and they're going to be on aspirin for a short duration of time. Later on, the P2 white will be added and continued for at least a year. Patient on antiplatelet agent who develops new embolic event. Again, we go back to primary prevention of heart disease, stable ischemic heart disease, history of acute coronary syndrome, cerebrovascular disease, peripheral arterial disease. So what are the associated underlying conditions? That's an important thing to keep in mind. And also we need to determine how far away from the time of insertion of the metal stent. If it's a bare metal stent, if it's more than a month, then we don't need to worry about antiplatelet agents. If it's a drug-eluting stent, less than 6 months, 6 to 12 months, and greater than 12 months, we have a different regimen. Same thing with the acute coronary syndrome, less than 12 months or greater than 12 months. So let's see what the recommendations are in the next slide. Here are the recommendations, which sort of mirrors what we saw in the previous slide with atrial fibrillation. This is for deep venous thrombosis. The previous one was for atrial fibrillation. Start these patients on anticoagulants. Then we can stop the anticoagulants after 30 days if it's a bare metal stent, like bare metal stent. But if it's a drug-eluting stent, then we can stop the aspirin and continue with clopidogrel. Same thing. We can 6 to 12 months for drug-eluting stent, 1 to 12 months. We can, but the preferred option would be to start them on anticoagulants and just simply continue them on clopidogrel. And this is similarly for acute coronary syndrome, and then for patients with PAD and stroke. You can just look through those. So ladies and gentlemen, this is a quick summary of PCI in patients with atrial fibrillation, patients with deep venous thrombosis, or when patients develop atrial fibrillation in the presence of a coronary stent who are on antiplatelet agents, or people who developed deep venous thrombosis when they are on antiplatelet agents. What do? The best option is 1 month of triple combination of antiplatelets and anticoagulants combination, and after that it's going to be long-term anticoagulation, 1 month for bare metal stent, up to 6 months for drug-eluting stent, or probably for a whole year, preferably for a drug-eluting stent. And then if these people are on anticoagulants, make sure their INRs are between 2.0 and 2.25. And also when they are on multiple anticoagulants and antiplatelet agents, use proton pump inhibitors and histamine 2 receptor blockers. Thank you so much for watching this presentation. We have a number of ACC AHA guidelines. If you want me to review on any other particular topic on ACC AHA guidelines, I will do the research, put all the information together, and explain it to you in a simpler manner. And please do subscribe to our YouTube channel. I will see you in the next presentation. Thank you so much.